All right. 1, 2, 3, 4, 5, 6, 7. All right. So I think you guys are mostly here. So my name is Francisco Kanajak. I'm filling in for Elliot today. And so the idea is that we're going to wrap up CT applications that you guys started last time. And I'm only going to talk for about an hour. It's only a presentation on dual source CT scanning. Is that right? Yes. Great. Do anyone have any questions before I get started? I'm trying my best to mimic what Elliot does. The only difference is I don't have the mic to record my voice, so my computer should be doing it. This I think I did for 280B and it worked out okay, so I'm trying. No guarantees though. Okay, so last class you guys covered a couple applications for CT in the cardiac space. Right, you spent a little bit of time looking at this diagnostic task of is there a stenosis in a coronary artery vessel. And so now that you can capture an image, and you had slides about how you can do it in heart rates, you can do it in a single beat. I think your presentation will talk about how long it takes to make a scan. You can think about it with one source, it takes you about 150 milliseconds to go all the way around. If you have two sources and they're offset by 90 degrees, it only takes you half as long. And so you can scan over 70 milliseconds. And that might allow you to freeze motion that's a little faster. So dealing with high heart rates might be one application. And so as the scanner technology has progressed, you now, as a radiologist, could look at this picture and ask, is this stenosis clinically significant? So I pulled this slide from Elliot's talk. You can cut these images here with the yellow line, and now you can look at it on FOSS and say, what is the area change, for example, in that vessel, and try to characterize how significant that lesion is. Another application that actually probably predates some of the modern CT scanners is looking at coronary artery calcium. So in this scan, you don't inject any contrast agent because the calcium already is bright on CT. It looks like bone. Right? And having that bright signal in the locations of your coronaries is a bad idea and a harbinger of adverse cardiac events. So this is again a slide that he showed where you can see on the patient on the top, basically the difference between your fatty tissue, which is the dark gray here, right, and your myocardium relative to your blood pool. And so even though you haven't injected any bright contrast agent here, so the vessels are kind of hard to see. But if you have calcium, you can see that it is this really bright signal. And so there's some standardized rules for how bright a pixel counts as calcium. You can imagine if something is 1% calcium in a pixel of blood, it may not be that bright, versus if it's 100% calcium, it'll be much brighter. And so there's been these large clinical trials showing that a certain rule or criteria for detecting calcium can be used clinically, and then also it has a higher ROC curve in terms of predicting it over any sort of clinical Framingham risk score, which is like your age, do you smoke, do you have family history, etc. Knowing whether or not someone has calcium or not significantly shifts this curve up. And so the reason why it's a curve and not a single dot is because you can vary what level of calcium you call significant. Right? So if you're over here on the bottom left, you're saying that the really high-risk people are only those that have calcium over 1,000. Right? So let's say that's a very small percentage of the population. And so you might be telling people you won't have any false positives, right? So the only people that fall into that group are people who really, really, really are going to have adverse cardiac events. Right? So you have low false positive rates. But you also are less sensitive, meaning there's a lot of people who will have events that you will tell them that they were normal. You can run the experiment the other way. You can be super sensitive, so the smallest piece of calcium would put you into this high-risk pool, and there you wouldn't be telling anybody that they're normal and sending them home and having them have a heart attack. But out of the people that you've detected, you'll have a lot of people who live perfectly normal lives without having that event. And so that is kind of a healthcare problem, right? The question is, what would you do? If you're talking about doing a surgery to these people, this can get really wildly expensive. Right? Whereas this might be the more tailored approach. You want to decrease people who don't really need the surgery, for example. But if it's giving someone a medication that's really cheap, or asking them to exercise and be healthier, kind of low cost interventions, you can deal with more of a screening protocol on the right. Okay, so we've talked about looking at coronary calcium, also delineating whether or not there's a stenosis. Elliot then had some slides showing that there's this discrepancy between stenosis burden or size and the hemodynamic change. Right? And so the gold standard way to tell if a stenosis is clinically significant is to look at the pressure drop across it. So is that stenosis flow limiting? And so usually you would have to snake a catheter all the way down someone's coronary artery. So it's a pretty high level of kind of burden of effort to get all the way there. Right? You have to have some amount of chest pain. You're not going to just cap everybody in terms of the screening tool. If you see any little abnormality, would you do this procedure? And so a company that came out of Stanford is it's called HeartFlow, and what they are doing is trying to come up with that pressure gradient measurement from just the images. Right? So you get a CT scan. Here, this is the volumetric coronary angiogram. You turn it into a finite element model, or a CFD model, where you have the boundaries of the vessel and something about the physiology. So what is the downstream myocardium that needs to be fed by the blood? What is this patient? Does this patient have a big amount of heart or a small heart, right? If you have a smaller heart, you have less grass to irrigate, and maybe you can get away with smaller vessels. Whereas if you have a big, meaty heart, you're going to need a lot of sprinklers. And then you can do this modeling to try to ask, is that pressure gradient significant? And so the idea is to eliminate the burden of having to cap people, making the measurement and saying, okay, this is normal. Right? And you got all the way there to capping somebody doing this really expensive procedure, and you didn't do any stenting or any intervention. And so the idea is that this could clear people that have what looks like a stenosis but isn't actually functionally significant. Put another way, it would give the cardiologist more confidence that when the radiologist tells them there's a lesion there, that it's something that they would intervene on, or that it would be functionally significant. All right, so that's the brief review of what you guys covered already. Any questions on that? Those of you who know me from 280B, I will wait you out for questions. So, yeah.
So, like, how do you measure the pressure?
Well, so how do you measure pressure with a catheter generally, or in that scenario specifically? So the idea is that you're trying to measure a pressure drop across the vessel. So there's a couple of nuances to the procedure. So you have a catheter that basically makes 2 pressure measurements, or you have one more proximally in the main coronary vessel, and then you go down to the point that you're interested in terms of right past the stenosis. There's another kind of component, which is that you want to do the physiology holds during maximal vasodilation of those vessels. So you're trying to ask, when the vessel is wildly open as it can from a vasoconstriction, vasorelaxation perspective, is it flow limiting? And so you then give a little adenosine to try to dilate that vasculature. So there's this procedural complication that is if you don't give enough adenosine, and if you don't make the measurement quite right, you can make mistakes. But it's thought of as the gold standard because that's what the interventional cardiologist uses to decide whether the stent in or not. And so if the goal is every time you send somebody to a cath lab, they should get stented. You know, given that it's a location that can be stented and there's no operative kind of snafus, it's a waste basically to send someone to a cath lab, make this measurement, and have it be normal. Like that's a waste of resources. Like that person should have been told earlier, yeah, you have a speck of something there, we'll watch it, but right now we're not going to put a stent in based on the guidelines. And so that is kind of the overarching idea. Any other questions? So today we're going to cover a couple other applications. So I think Elliot maybe had a slide on this in terms of angiographic phenotypes. So moving beyond just looking at whether the vessel is pinched off or not, but actually asking what is on the outside that is causing that impingement. Right? It can be a useful diagnostic measurement. We can also look at perfusion with CT. And then that will also kind of dovetail with what we'll do in terms of looking at cardiac function from 2 or multiple phases across the cardiac cycle. And then lastly, the use in procedural planning. Right, so there's a couple of procedures here, for example, getting your aortic valve replaced with a catheter that has been a big boon to CT for the heart because you surgically open up the chest and then you look and say, okay, what valve do I want to put in? And you maybe try a couple or you adjust. When you're putting it on a catheter, you've already made your choice with what you've put on the catheter. right? And you're going to snake it all the way to the heart, and then you're going to deploy it. But you already have to have kind of measured or guessed what valve you're going to put in. Right? So that has increased the burden on diagnostic measurements that you would want to make and say, is this valve area smaller or bigger, or which of my 3 sizes should I put on the catheter? And then I think we have the presentation at the end. So this is kind of our current overview for today. Okay, so this slide I think is a review for you guys from what you've done earlier. I just showed it earlier today with the coronary calcium. And so you can think of having any distribution of patients that are both normal and abnormal. And if a parameter is predictive, there's a shift of this distribution. And now the question is, what cutoff value here for your decision parameter do you use to separate these 2 groups? And you're often making a trade-off of how many people you're going to say are diseased when they're really not, versus how many people are you going to tell that are completely normal when in fact they're not. When does this become perfect? If this decision parameter perfectly separates these 2 groups, right? If the histogram over here was over here, and then the other one was all over here, any of these values in between would be great. Right? So that often ends up not being the case from a statistical perspective and kind of other confounding variables. Right? But the optimal value is to be on the top left corner here, which is when you have a value that perfectly separates group A from group B. Okay, so using that definition, you should be able to kind of put into words what it means for a cardiac angiogram to have a high negative predictive value. Right, so what does that mean in words? You go into the doc tomorrow, you get a CT angiogram, and they tell you some result. If I tell you that the study has a high negative predictive value, what is the result that you can feel confident in? Yeah.
Does that mean that if they say that you're clear in your head, you don't have a problem, that there's a really good chance you don't have a problem?
Exactly. So if I tell you your coronaries look fine, or I tell you you have disease, the statement you can take most confidently is the fact that your coronary vessels are fine. Right? So the point here is that if your vessels look like that, there is no like hidden lesion that we maybe missed that was kind of there and it shows up later, etc. If your vessels look perfectly clean like this, the chance of having an adverse coronary event over the next 5 years is something like 0.0001. Okay. Conversely, though, if I told you you have significant coronary disease, you would go home, you'd freak out, and then there is still a kind of outcome, which is you go down this rabbit hole and you're cleared. And the reason is that things may have moved, something may have looked smudged, right? And the radiologist didn't feel comfortable saying you were entirely clean. But there are ways in which you could fall in the this is suspicious bucket that are not in fact true. Okay, so the statement you can really take home is that if your coronary vessels are clean, you're great. And I think Elliot used the example of like airline pilots. That's why they kind of recommend this, is that if you're clean, then you're good to go, and you don't have to worry about this person having an acute MI when flying the plane. Right? It's a screening protocol. Right? But then you can have cases where you have significant stenosis. Right? And so here I'm trying to show a couple different renderings. So here this is a volumetric rendering where you can actually rotate the heart and look. And we've basically gotten rid of the myocardium through a visualization process and are only showing the blood pool. Right? And so this vessel is supposed to taper off in kind of a normal linear way as the vessel gets smaller and branches. And so having anything where the vessel diameter decreases and then increases back up again is problematic. You can kind of see it here on this two-dimensional slice, although that's always kind of fraught. You probably want to look at it from multiple views. And then on the right-hand side is the corresponding angiogram, that when you went in and put a catheter into this vessel, you squirt a little bit of dye that opacifies the image, right? So it turns black because it eats up X-rays. And you can see the branching pattern and see that there's this lesion there. So what's the difference between the picture on the right and the picture in the left too? What type of picture is the one on the right? I'll give you two options. Is it a tomographic image or a projection image? What do those words mean? What is a tomographic image? Yeah, kind of. And that's a part of it, but it means that it's a slice. Right? It's like a prosciutto slice or a deli slice. A projection image is some summation. So the one on the right, what you want to be careful of is that it's a projection image. Right? You're shooting a 2D X-ray, kind of like when you see your chest X-ray, through your vessels. And so things can pile up in ways that maybe mask or hide the true dimensions of certain things. Right? When you get a chest X-ray, you can't tell really if your heart is in front of your ribs or behind it or inside of it, because they're all added together. But in a CT slice, you can tell, right? So like here, you can tell spatially this vessel is in front of that one, etc. However, if that vessel is really pinched down that way, there's no way anatomically that a vessel can be that pinched down and give you a falsely bigger reading than it is. In fact, it may be worse than what you see, right? Because if it's at an angle, you might be coming very thin, but if you tilt it, you may not see it. So oftentimes they get multiple views in projection angiograms to look at, is it really 90 degrees stenosis? Is it worse than that? Okay, so on the one on the right, the other thing is that you don't know what is out here. Right? What is causing this impingement? And so on the CT scan, you could now look around here and ask, is this muscle? Is this calcium? Is this fat? And get a better sense in terms of the phenotype or the physiological process that's happening in someone's coronaries. Right? And so that's kind of the rationale behind developing these CT angiographic phenotypes. So on the top, we have the coronary calcium picture. So you can see there's no calcium on the left and a huge bright signal that looks like bone. So that would be someone that has a calcified disease process. That might be different than some sort of diabetic disease process, for example, or lipid-filled process. Here you can think of having plaques that are heavily calcified on the right, partially calcified here in the center, or actually have a soft kind of myocardial tissue lipid-filled portion. You can also see here, for example, the idea of having a thin fibrous cap. Right? If a plaque has a kind of thin boundary that is holding it, the idea is that that's like a vulnerable plaque that might rupture, whereas calcified plaques may be more stable. If you think about it, you have this thing that's sitting there, you can think of it as a ticking time bomb. And the question is, like, what is the likelihood of it exploding? Right? If it's entirely stable and dormant, then it might impinge blood flow when you're running a marathon, but it won't necessarily give you a massive heart attack. Right, which has this more of a rupturing acute phenomenon. And so you might want to treat those differently. Right, the other question is, you can tell whether someone has little bits of calcium everywhere versus kind of a long sheet of calcium. So a lot of these have been investigated in terms of their prognostic value. So kind of the hallmark would be, do you have a stenosis that's more than 50%? Right? This doesn't care about what's outside. This is just asking about the inside diameter. Right? And the relative hazard ratio is 34%. So the rate of if you have a stenosis greater than 50% versus those who don't, right, the risk of having an acute cardiac event is 34 times higher if you do have that sign. So the other thing you can ask as well is the stenosis so significant that it's bulging the vessel outward? Right? This type of positive remodeling. Think about your blood vessel is dealing with, it's a fluid dynamic problem on the inside where there's flow going through, and now you put this obstruction, and one of the things it's going to want to do is push it out of the way. Right? At some point, there's a balance there between how much it can obstruct the flow and how much the vessel will hold that pebble or rock in the way. Right? And so if you have this positive remodeling, now you have a riskier plaque than if you don't, and that's an 11-fold risk. If the stuff in the plaque has a low Hounsfield unit, meaning that this is more fat or lipid deposition, that also increases the risk. Right? And so there's a phenomenon here which is like there's some remodeling, there's some cells that are eating away at some plaque features, and they can kind of rupture, and so there's this physiological kind of idea and it causes an increase of 8 in terms of your relative ratio. You can see that these are kind of decreasing, but the idea is that you're trying to get a phenotype for any one particular plaque. Again, if you can see this kind of napkin ring sign, so there's a thin cap. Or sorry, here this is where you have a huge bowl of lipid in kind of one concentric area. The other one is whether you have spotty calcium. Right, this is somehow heterogeneous. That is associated with the worst finding. So if you had to kind of draw what your coronary angiogram looks like, you can think of a scenario in which having it be over or under 50%, having it have calcium or not calcium, having it have lipid or positive remodeling, you kind of go through the checklist as the radiologist is describing the picture and kind of adding up the risk in your mind. Right? It doesn't necessarily add up linearly, but these are all different risk factors. Right, so you put this all together and see that sometimes positive risk value is really having a high percentage of stenosis, any high-risk plaque, or all high-risk plaques. You kind of see how, depending on how you define it, you can do your statistics slightly different. Right? So here is having a stenosis, having any of the high-risk features, having nothing but high-risk features, having positive remodeling, having a low Hounsfield unit, or having spotty calcium, and how your patients get distributed amongst those two populations. Yeah?
What is risk considered? Like, is it like percent chance that you'll get an acute MI or what?
Yeah, so I think the way this is the relative risk, right? So this is having, you have, let's say, 10,000 people, and let's say 500 of them had an acute coronary event over some period of time, over 5 years. And now what you're doing is you're going back and you're looking at their CT scan and say, when I ask who of those people had a stenosis and who didn't, they distribute themselves like this, right? So the people who had greater than 50% had a 65% of having rate of having a stenosis, whereas people who didn't had this rate of 2%. And so the relative risk is the ratio of those two numbers. Right, so 1 means that it didn't separate them at all. Right, it goes to infinite if you perfectly separate out the two groups. Okay, so we said that one of the takeaways you can take, the statement you can feel confident in is you go to the doctor, you get the scan done, and tell you have no disease. And so what would the reasons be for having some disease? And they're shown here. Right? So one of the reasons is poor image quality. So if you look at how robust the technique is, out of something like 6,800 segments in this study, 202 of them, the radiologist said, I can't tell. Not that there isn't disease, I just don't feel confident making that decision. So the question is, why would that happen? Right? And so if you then look at another way, is that out of the 472 patients, 15 of them at least had one segment where your answer is, hey, everything kind of looks good, or we have some disease here, but we have this one thing here that we can't evaluate. Which is essentially like an incomplete study. Right? Your option is either you live with that uncertainty or you have to get the scan again. Neither of those is a kind of an ideal scenario. Right? You don't typically get a blood draw and it comes back like, sorry, couldn't tell your blood type. Right? That's not usually a kind of valid answer from a test. So the most common culprit is motion artifacts. And we'll show some pictures in a minute, but if your vessel is moving, or moving at a high enough velocity during your scan, it will look kind of like a bird. An elementary school drawing of a bird, like a little arc. And the radiologist then has to guess whether or not that is something that is open that has moved, or something that is kind of dimmed and moved, and that is really challenging. The other thing is that the calcium could be nearby, and because it has a point spread function of its signal, can kind of mask or bleed into the vessel, and then you're not sure if the brightness in the vessel is because of the iodine or because of the calcium signal that is kind of bleeding through. And so instead of saying, that's totally open or that's totally closed, you may just say, I can't evaluate. Right, lastly, if you're big and the x-rays get eaten up by non-coronary tissues and your detectability goes down, or if the injection that they put in was not robust enough in terms of enough iodine made it to your heart, that might decrease your confidence in saying that that vessel is actually open. So if you think about it, if you go to the CT scanner, you lay on the table, someone's going to put an IV in your arm, and the first question is, what size IV were they able to put in? Right? If they're a very small diameter catheter, you may not be able to push at a rate that's fast enough to really mix with your blood and cause a big signal increase. The other thing that they're going to do is they're going to give a bolus that has it's injecting for 10 seconds and then it stops. And so now that iodine is traveling up your arm, into your veins, mixing, going into your lungs, and then you take a picture when it's in your coronary vessels. Right? And so you can kind of approximate that transit time. And there are techniques to monitor it and try to tell the scanner when to go. But the kind of biggest crux, I think, in the whole problem is that once you say, okay, I think it's in the lungs, it's going to soon make it to the coronaries, you have to ask the patient to hold their breath. So you make the decision to go, like let's say 8 seconds before, you then say, okay, now take a deep breath in, take a breath out, and hold your breath. And so you can't just be waiting and like immediately scan. You're asking someone to hold their breath. And you can't just like ask them to hold their breath instantaneously, you have to kind of give them a heads up, like I'm going to ask you to hold your breath for 10 seconds. So that mistiming could mean that you shoot too early or you shoot too late, and now the contrast is lower than you wanted. Yeah?
So it seems like there's methods for mitigating a mature artifact before contrast to noise ratio. What's like the standard for the coronary calcium? Is there a way to kind of, get rid of the effects of that?
There's still kind of in the works. Probably the most promising one is to do a dual energy or material decomposition of the scan. So the idea is that if you shoot at one X-ray energy, the material's attenuation constant value is just one number. But if you shoot at multiple energy values, the slope of the attenuation is a function of the material that it is. And so if you had, for example, 5 energy values that you shot at, you could ask, is this iodine or is this calcium or is this predominantly water? And so that would allow you to now ask how much of this pixel value is iodine versus calcium and get at it that way. However, then how you do that, you now have to, for example, take 5 pictures and hope the heart is in the same spot every time. That would be one challenge. I think we're going to hear about the dual source, where if you run them, one source is at one energy and the other one's at the other, you kind of can get them at the same time. And then the last technological approach is Philips has a detector that separates out the energies on the detection side. So you separate out the signal of high energy photons from low energy photons on the detection side, and so it is kind of like instantaneously registered. And so this has more been a question of how vendors actually try to do it. But from a conceptual perspective, if you can ask what is the energy, attenuation as a function of energy, that might be the most promising way to do it. Okay, so yeah, all right. So these are a couple examples of what you could get in a CT scan. So on the top, this is kind of a high energy and high current and low current scan. Right? And with the low scan, you still see a lot of the same structures, right? If I ask what this is, you can still tell. Right? And so you can still see kind of that it's a heart, it's appropriately sized and shaped. But that's your left anterior descending artery. Right? And your ability to tell that that is open or not basically disappears. Right? You just don't see the vessel. Right? So, for example, telling the size of is your heart too big or too small, that's perfectly fine. You can get away with very low dose to do that. But whether or not this vessel is open or not is a kind of high dose task. Similarly, you can see how the calcium here, at least in this view, shows a channel in between. That is kind of where the vessel is open. But that starts to blur if you have a lower dose scan. It's kind of shown here on the difference image. Maybe that's easier. Right? So is this vessel open? At least the calcium seems like it's stuck on the outside walls, right? But the impression you get here is that this thing might actually be blocking the whole vessel. All right, so then this is now if you take a picture across the cardiac cycle. Right, let's say you make 20 pictures across the heart cycle. In reality, to make the coronary artery measurement, you just wanted one picture. Right? One static picture when the heart was not moving at all. And so I think the point I want to make out is that if this is your right coronary artery, you can see that sometimes you can tell whether it's open or not, and sometimes it's almost impossible to tell where it is at all. Right? And this is because you're capturing a motion of, you can see that it contracts, and then there's an atrial kick, and it moves this way, and then it contracts again. Like, I can't really do it anymore. Yeah, there we go. So you can see it bounce to the bottom, and then goes up and then back. And when it's moving at a high velocity, it creates these arcs. And if that would be the only picture you had, you can't really tell if it's open or closed. So if you were running a CT shot for the heart, what could you do? You can decide, I'm going to scan the whole heartbeat. So instead of getting one picture at like the resting, end diastolic phase, I'm going to just scan for a second. And then I'll hope or guess or let the radiologist scan through these pictures and pick the one that they like the best. Okay, so in terms of having non-diagnostic scans, that would decrease that risk. But what would you be doing? What's the price? Yeah, so instead of exposing the patient to 150 milliseconds of dose, we're now going to scan for a second. Okay, so that's 8 times higher than radiation dose. If everything is kept constant. Okay, so maybe you do that in a subset of patients. Patients who have variable heart rates. So the idea of picking a good time frame prospectively, like you say, okay, I'm detecting your ECG and I want to pick this point. If it's really robust, like you've got a pacemaker and it's giving you exactly the same heart rate, that's a trivial task, is to determine when to scan. But if someone's heart rate is bouncing all over the place, maybe you say, okay, in those cases, I'm going to just scan for a second. And that's what they do. So there's a kind of a heuristic on the machine. It says, I'm detecting all this heart rate variability. I'm going into mode B, which is just to scan for a second. But if you were scanning, your heartbeat was perfectly regular and low enough, it wouldn't actually do it. So maybe you scale it for not everybody, but for the people that you're a higher likelihood of missing the right heart or the right phase of the heart. So the other thing you can do is you can try to correct for the motion. So this is an algorithm coming out of GE, and the idea is if you have your main picture and you have a couple picture a little earlier and a little later, you can try to infer if the vessel is moving during the scan. And because this is kind of a small period of time, you can infer it with like a linear motion model. So if the vessel drifts a little to the left or right during the 150 milliseconds, and you kind of query it from a slightly earlier picture and a slightly later picture, you can try to estimate what the motion is. And once you have an estimate of that, it's not any different than, in theory, from the scanner's perspective, the patient is rotating at 4 Hz. Right, so now what you're saying is not only is he rotating concentrically, but he's also drifting over things. And so if you build that into the model, you can now make movies here where that vessel is pretty clear all the way through, like even in the periods of high motion. So to make any one of these pictures, it's not sufficient to just have 180 degrees of the data. You now have to have a little more on either side. So instead of scanning for a second, you now maybe pay a 30% penalty. Instead of 8 times higher, you pay 30% more. You get these extra views, but you can increase the number of readable scans. And so you're trying to embed more information into the reading. So any questions on coronaries? So we talked about trying to make this anatomical delineation of stenosis. We talked about the phenotypes that you can define or infer. And we talked about motion being one of the main artifacts that you have to overcome. Okay. So the second thing you can try to do is measure perfusion. So I think this is supposed to be a movie that's really, but we can try to get that up on the website. The idea here is that instead of waiting for the contrast to make it all the way into the coronaries here and taking this picture, you actually plot how your myocardium's intensity is going up as the contrast goes into the myocardium. And in theory, it's going to go down the coronary arteries, and then go into the capillaries, and it's going to stick around and come back out. And so the idea is that something that is hypoperfused or obstructive would have a delay, it would have a lower attenuation value that is the peak of this curve relative to the rest of the myocardium. So now, the idea here is that you can also do this in the same injection. So you're scanning someone, you're giving them the contrast, it's going up their arm, it goes into the right ventricle here. And while that is happening, before you take your scan for your coronary, you can just take a picture every second and watch this curve go up and come back down. And so it can give you a complementary functional parameter that is not really the stenosis anymore, but it's what's the downstream impact. And so do the myocytes see less blood perfusion? I think I can go to this. Wait, give me 1 second. Right, so you started to inject, I think you see the picture on the bottom, right? So you start to inject, and you're starting to scan fairly quickly at the beginning. And you see that the arterial input function goes up, and your tissue is going to be delayed. Right? It's obviously going to have to come into the arteries first, and then make it to your myocardium. But as you sample this, you can tell, okay, this is my input function, and then this is what the tissue saw. I think you want to see the picture on the bottom right. Here right now, the blood is already washed out, and it's kind of, oh, there you go, homogeneously gray. If I go back, you can see here, there's an area that is still dark, whereas the rest of the heart is much brighter, right? Meaning that is not receiving any of this iodine that would make the signal go up. Right? So if you look at these curves, you can either look at the maximum slope, or the peak, or the integral. There's a lot of different mathematical models. But the idea is that you can then make a map here of perfusion. And that area that was slow, or the maximum intensity value is low, will give you an area of lower perfusion. So this is a kind of independent parameter, and you can do it in the same setup. Right? But the only difference now is you're getting not just one picture here, which is a typical coronary, right? You wait until your arterial signal is highest. That's when your coronary vessels will be lit up as high as possible, and this is the picture you take. That was our earlier scan protocol. Now we're taking pictures every 1.5 seconds. Then we get our coronary scan, and now we want to follow it up with pictures every, for example, 5 seconds. So to get this functional information, you now need 20 scans instead of 1. The nice thing is that what we showed earlier is you don't really need a high dose to look at these things. So you don't necessarily have to run them at the high currents that we talked about earlier for the coronaries. You can do them at a lower current value. You can also run them at a lower spatial resolution. Right? Your perfusion is not this little tiny 1 millimeter vessel that is open or closed. It's happening over large territories. Right? So this picture here doesn't need the highest spatial resolution in terms of the color match. Right? Because it's going to be obviously a spatially homogeneous or a spatially coherent territory that will be hypoperfused, right? If a vessel is obstructed. So you can change the scan parameters a bit to overcome the fact that you have to take many more pictures. So now there's a question of what you're tracking is the intensity of that value of the myocardium, right? So what is the intensity value in Hounsfield units as it goes over time? And the question is that a robust measurement or not? Right? Earlier we talked about the brightness of the coronary vessel, but we never were really measuring the brightness of it. Right? It's not, if it's 500, it's good, if it's 489, it's bad, right? Where you would have to measure that accurately. And so there are a lot of things that can impact what is the measurement you make in terms of intensity of a piece of tissue. Right, so one, we talked about motion already, that it moves edges, and if you're capturing the wrong cycle, you may get a mix of blood and myocardium in a picture. Some of the data is old, and some of the data is new, and the heart is moved in between. The other thing that can happen is that bright structures like the bone and the blood volume in the LV can cause streaks. Right? It's kind of like a halo sun ray effect, and those can fall into the myocardium that you're trying to make your measurement. And so that can increase or decrease your signal value in an artifactual way. There's also beam hardening, which is a kind of path-dependent process that if you, for example, come through the front of your body and then detect out the back, the x-rays that are making it to your heart will have to go through, for example, your sternum, which is a different path and will have a different attenuation than if they came in from the side, where the ribs and the spine aren't there. And so you can actually get artifactual differences in attenuation because of this beam hardening effect. So to kind of show these effects, if you look at this picture, the intensity here in the myocardium appears to be homogeneous. Right? And this is a function of how we visualized it. We're really trying to highlight the difference between the blood volume, or the blood intensity, and the myocardium. Right? Not any subtle differences in the myocardium itself, but just the fact that there's a bright area and a gray value. Right? Or this has basically three tones. It has the bright value, the gray value, and air. But if you zoom in on what is the intensity around the heart, you can see that there's all this heterogeneity in what look to be the same gray value. Right? And that's on the order of the perfusion signal that we're going to measure. Right? And so the question is that really myocardial signal? Like, is that perfusion based, or is that just an artifact? Right? So here you can see this movie. Again, this contrast is not sufficient to look at the myocardial window. But you can see that there's maybe some flickering that you can tell in some of the gray areas based on the gantry spinning around. And so that's if you change the leveling, the window level. Right. Why can I say that this isn't really a perfusion problem? What gives that away? Or what would be your kind of apparent justification?
See the noise like spinning around the picture.
And that would correspond to what?
Spinning and collecting different angles.
Right, so there's kind of a model that you can think of, all right, in one of these views the scan was directed in this direction, and now, one frame later it's pointing in this direction, and it seems to spin in a way that makes sense given scan acquisition protocols. Okay. The other thing is that this is all one heartbeat, right? This is like the heart's beating. So this isn't, the time scale is 1 second, right? This is not the perfusion time scale. And so in theory, all of that attenuation should be the same within a second. Right? The perfusion has already kind of come and gone, or it's flattened out. And so these variations are too fast, basically, for the time scale you're talking about. Right? So now the problem is if you take a picture of this piece of myocyte every 5 seconds, and your gantry is in different positions, you know you're going to be going through basically this halo ringing effect on top of your signal. And so how do you account for it, or how do you take it out or decompose it out of your signal? So the other idea is that maybe you don't need all of the signal the whole time course of your perfusion. What if you just make a kind of informed guess and you say, I'm going to take the maximum value? So there's kind of approximations you can make. You know that the background value is always the same. So if really all of myocardium is always 100 pound-per units, and what is increasing is the maximum value, you can just take that one value and call that perfusion. And so that's the idea behind this protocol, where it's static perfusion. So basically, you're assuming that the background value is the same. You know the time course between when maybe the injection started happening, and building more into your model, you can now just take one picture. So this is at one heartbeat, and it's 1.2 milliseconds, which is way lower than a standard perfusion. And from that data set, you get not only kind of what the RCA's disease looks like, but then also what is the territory that you think is affected. Okay. Any questions on this? All right. So if you wanted to measure cardiac function, the fewest number of frames you could acquire, right? Given the fact that every time we pay a dose penalty, is to get 2 frames. Okay, when the heart's at its biggest and the one's at its smallest. Okay, you have 2 volumes, and you can ask, for example, here on the ECG, we took a picture in systole and then during diastole, or diastasis. So here, maybe on the right-hand side, this is where we would do our coronary assessment. And so by getting 1 second picture, you can now not only ask, are the coronaries open or closed, but what's the ejection fraction of the heart? Are there certain areas that did not thicken appropriately? Is there a wall that's not moving from that visual assessment? So you can see here the change, for example, in the conformation of the heart, right? The blood volume goes down, the walls thicken. And so if you wanted to do it in the most dose-efficient way possible, you just need to add a second frame. And in fact, this second frame can be much lower dose, because you don't really care about the coronaries, you just need one of these volumetric analysis measurements. The other thing you can do is you can keep the movie on and start making pictures that look like echoes. Right? So these are 3-dimensional data sets that are acquired over time, and so you can reslice them in any orientation you want. And I'm pretty sure you guys have already covered what some of these views are and what the structures are. And so you can make something that looks like a high-quality echo in terms of its spatial resolution. Temporal resolution is debatable about whether or not it's better or worse. So this looks pretty normal. Is this normal? So who spies the abnormality? Everybody? Nobody? You go in and tell the patient, all right, we got your scan back, and it looks like everything's great. Is that normal? Go back. Okay. Right. These seem to be contracting fine, but this part really isn't. One thing to be careful of is that at some point you're going to hit the aortic valve, right? So is that over here? If you keep going up, right, you're cutting, so these are 3 slices that are cutting like this. And so your top slice is basically somewhere in this area. Right, so on this picture, where do you expect the LVOT to come out? At what o'clock? Right? So there's 12 o'clock, which is north, 3 o'clock, where is the LVOT coming out on this picture? You kept going up. It'll basically split the RV. It's going to come out here. Right? So that kind of gives you an indication that this is probably not just the fact that you're getting into the valve that is less contractile. This is actually kind of a dysfunctional piece of myocardium. Right? So if you can see it here, at some point this kind of goes away and the aorta will come out this way. Does this look good? Where's the other mouth? See it here? So what this view corresponds to taking this middle slice of thin. It's thin, it's not eating, it's not cooking. Is it hypoperfused? Long stain. It doesn't have the perfusion time course. Is there a coronary lesion that explains this? Also, long stain. Right? We have to go back and find the thing that where the coronaries are not moving and hope that we had a high enough dose to look at the rest. So not only can you look at the LV, but you can also look at some of the other structures. So this is your left atrial appendage, and your LA is over here. So the idea that your LA is going to contract and fill the LV with blood, well, it contracts, but it's filling. And this little chicken wing that's attached causes all sorts of problems. Okay. You can have atrial fibrillation in which that ventricle is not contracting and it's disorganized. And if you have that, then this little chicken wing ends up having what can have stasis. And the idea is that that is a place where clots can form. So you could tell, at least, for example, here, what is the ejection fraction of that vessel, of that little chamber? Is the atria contracting in a uniform, reasonable way, such that there are nice flows occurring in that chamber? So you can make measurements that are volumetric, for example, ejection fraction, which is just what is the change in volume as a percentage of the initial value. And so in systole is a smaller volume and diastole is a larger volume, so that difference is the stroke volume that came out of the ventricle. And as a function of the initial value is the percentage. You can also use a longitudinal shortening as a one-dimensional or linear measurement of impact rate. So the last thing I want to point out before we talk about procedures, you can see, okay, so this is the inside of a heart. If you flush it out with saline, this is the kind of complex structure inside of the myocardium. That's that earlier diagram of like this convex bullet-shaped thing that's smooth is not active. And in fact, if you have a high enough scan, you can start to see those structures. There we go. So this is a cast of the blood volume, and it gives you all of that high spatial resolution structure that is there. And because that's a material property, right, those features can move and deform, but they're part of the myocardium, you can use them to try to visually perceive what's happening. Right? So here's that infarct. And if you come around, you can see that those textures aren't really deforming in that area of infarct relative to the other parts of the heart. So one of the things our lab and Dr. Elliott has done, Dr. Mayor's done, is to track that over time. Right? And use it as a fiducial marker to tell whether something is deforming or not. So the idea here is that you can do some non-rigid registrations and tell, for example, this is the conformational shape of the heart at rest, and then as it contracts down, little pieces are contracting and turning blue, and there's an infarct here that is remaining yellow, and that area is not deforming down. Right? So instead of visually looking at the infarcts, you can actually do it quantitatively. And so, for example, this is what a bunch of normal patients look like. They all have very similar function. This is all the different segments in the base, mid, and apex of the heart. And so we got some normal values. For example, this is what one standard deviation away from normal looks like. And now if you were to look at a patient who has a regional dysfunction, you can see which number of segments are affected and how much. Maybe they're not getting as far down in terms of their contraction, maybe they're late. So you can look at both the temporal and spatial information. So again, one of the things to be careful is because we're spinning around and the heart is moving, if you happen to hit the wrong frequency, you can actually see this motion artifact, that is, the walls appear to be moving in a stepwise fashion. And that's not really how the heart moves. It's moving in this way. It doesn't have these discrete chunks. That's a function of your sampling. Okay. You can also see that they're not holding their breath because the rest of the chest cavity is moving up and down. You can see it goes up and drops back down. The drift. So I mentioned this earlier in terms of procedural planning. If you're now going to put a valve on a catheter and stick it in someone's groin, and snake it all the way up their aorta to their heart, you want to know what size vessel or what valve to put on that device. You can also use the CT scan to make sure that that device fits all the way down the aorta. Right? Are the vessels pushed down? Are they obstructed? So not only do you want to know that the device fits, but then what is the diameter here? But you want to make sure you're not going to hit or close off a coronary artery that's right above it. So they do these pre-procedural scans where they measure not only let's put in a 25 millimeter valve or a 28 millimeter valve, but they also check that your coronary vessels here have some amount of clearance so that when the valve opens and deploys, you don't give someone a heart attack. So you have to have some amount of tolerance in where you put the valve, and the valve has slightly different skirts. And so this is being used a lot clinically now. The other thing you can do is a more wholesale fitting of devices. Right, so LVADs are left ventricular assist devices. These are pumps that pump for you. So the idea is that you're going to implant this into the left ventricle and suck blood out, and through a continuous flow pump it right back into the aorta. Right, and so someone can go from having a pulse to being pulseless and having kind of steady state flow. So one question is, like, does it all fit? Right, there are some structures that you can move around and some structures that you can't. Right, so does it fit within the rib cage? How much do you have to displace the lung or the mediastinum? How do you burrow cables in and out? These people then wear battery packs that power this. And so you're going to have access to that. Some of the work Dr. McBaseline has done is to look at now that chicken wing that I was showing earlier, left atrial appendage. This is the type of device that you can deploy with a catheter to try to close it off. Right, the idea is that you put this device in, at some point it would seal over with endothelial cells, and that kind of area of low flow that could become a clot that would fall into your circulatory system would be closed off. The challenge there is that these chicken wings have a wide variety of shapes. And you're trying to put this singular device, and the question is, does it fit? Will it actually close off that orifice? Am I going to realize that somehow I have to tilt it or angle it a certain way? And so again, because you're doing this with catheters, you would like to do some planning ahead of time and maybe pick the right device off the shelf or give a patient a probability that that device procedure will work. Maybe you give it a shot and you end up having to not deploy anything because it doesn't fit. But you can kind of give that risk assessment further. Yeah?
What is the role of the left atrial appendage? You can just close it off like that.
Yeah, it's thought to be like a vestigial organ. Right? So in theory, it's kind of a pop-off valve. If your left atrium is experiencing higher pressures, the flow can go into there, the volume can go into there, and it can descend, and it doesn't really, so it's not inline, which is what's crazy. So you can close it off. There's also surgical procedures where you tie it off from the outside, and the idea is that this catheter procedure is kind of less invasive. But because it's this little outpouching, it doesn't seem to affect anything. It also isn't entirely obvious that you need it in terms of contractility of the atrium to fill. It has to pump because or else the blood from the atrium would just go into it, and you just have this sloshing around of blood. And for it to go forward, everybody has to contract kind of at the same time. And so in fact, it's just maybe a more complicated piece of equipment than we want to do. Okay, so we covered CT angiogram phenotypes, perfusion, function, and procedural planning. In the last 20 minutes, I guess we can have you come up and give your dual source presentation. Any questions? Before we do that? No? Okay, great. What was that? What about it? Can you please submit your homeworks? Thank you.
me start. Hello, my name is Kyle. This is Yu Yang, and today we'll talk about the attenuation correction of SPECT in myocardial perfusion imaging. So the purpose of this presentation or this paper was to review the multiple approaches of the SPECT attenuation corrections, and also to understand its limitations. Take-home message: it is really important to have an attenuation correction for the MPI. So before I dive into the actual concept of this main concept of this paper, I would like to talk about the attenuation a little bit. So attenuation, as we all know, is the probability per unit length path that occurs, that interaction will occur. So in CT, attenuation coefficient is expressed in Hounsfield units, which is related to the water, and in CT, attenuation coefficient, is using this Hounsfield units. And in PAT, attenuation coefficient is calculated along the total path, whereas in SPECT, it is calculated from the point of emission in your body in the direction of the detector. So the spatial distribution of the attenuation coefficient in SPECT is unknown, so it requires the reconstruction of the attenuation distributions with the additional informations. So there are indirect approaches and direct approaches. So indirect approaches have their limitations. For example, the planar imaging, it uses the 2D images where very few physicians and technicians are familiar with using 2D images to address the problems in soft tissue attenuations. So these types of limitations led to devise the algorithm that directly approaches the problem. So it is considered as ideal if this approach does not interfere with the workflow efficiencies, and it also should not create any additional artifacts. So these are the systems that are currently used for myocardial perfusion SPECT attenuation corrections. In figure A, we have the two dual 90-degree detector system. It has the two collimated line sources that scans through the patient's body and detect it on detectors. So this system uses the radionuclide called the gadolinium, GD. It generates the energy around 103 keV. So the good thing about this system is it allows the maximal separation between transmission and emissions. But in practice, it generates the crossover of photons. So that causes the artifacts. It also has a limited field of view and also limited strength of source. In system B, we have the 14 external radionuclide sources that are also projected through the patient's body and detected on detectors. And it gives the greater transmission sensitivity compared to the system A. It also uses the same radionuclide source as system A, which is GD. But as we increase the transmission field of view, it also increases the crossover of photons. So that causes another limitations, such as artifacts. In system C, we have two scanning point sources that are aligned right next to the detectors. And these two scanning point sources are transverse to the patient's body with different angles. But good thing about this system is that it uses the high energy energy radionuclide called the BA133. It releases the energy around 356 keV, which is 3 times higher than the previous two systems. So because this high emission energy allows the BA133 to place well above the other two tracers or the radionuclides. But it also increases the down scattering into the emission windows. So these days we have the hybrid dual SPECT and CT system, which is a combination of the SPECT and CT. So CT images are used for creating the attenuation map, and then we can maybe apply that map into the SPECT, so the attenuation, how that changes. So a good thing about this system is that it has a high degree of resolution, which allows us to actually visualize the artifacts, which we're not seeing with the lower energy sources. But CT might have its own artifacts, such as a beam hardening due to the stents, metal stents in patient's body, in coronary stenting, such as coronary stenting. So it is really important to study the attenuation corrections, but at the same time, we have to account for the multiple artifacts.
So when obtaining the attenuation map with the CT or external radio nuclear source, there are a couple of artifacts that can happen. The first one is the insufficient transmission count density. That is not a problem for CT, but it's a problem for external radionuclide sources. So when dealing with a patient with a large body size, the transmission count density might be not sufficient enough to obtain the full profile of the attenuation map. So one way to solve this artifact is to perform a short pre-scan to calculate the acquisition time. And as you can see, the top row is the map without the. Oh no, that's for the second one. Okay, sorry about it. So when treating with a patient with large body size, the image truncation can sometimes happen. So when the part of the patients move outside of the detector field of view, it can cause image to truncate. So the top row is the image without the truncation. And the second row is the one with the truncation. So as you can see, the left side of the patient's body is truncated, leaves a bright signals. So this can be solved in both software side and hardware side. So for the hardware side, we can increase the detector field of view to cover more FOV for the patient's body. For the software side, we can use a reconstruction method that's less sensitive to truncation. And as mentioned by Kyle, the SPAT and CT system as doing the image captions at the same time. So there might be a downscatter artifact where the detector of CT or the detector for the SPAT cannot identify the source of the signals. So as you can see, the top row is the one with the downscatter artifact. So in here, you can see the mixture of signal from both sources. This is the one that corrected for that downscatter artifact that gave us a very clear view in the middle of the image. So one way to solve this artifact is to do a sequential acquisition of emission and transmission scans. Instead of doing CT and SPAT image at the same time, we can perform them alternatively, like take one CT shot and then followed by a SPAT image. Another artifact is the misregistration of emission and transmission scans. So when we are using the CT system to obtain the attenuation map, we need to make sure that the attenuation map match the orientation of the SPAT image. As mentioned by the paper, a shift of 2.9 centimeter will raise the error by 30%. So beside all solutions mentioned, there are more solution lists in the papers about how to reconstruct the map. So for the CT imaging system, we use a conventional filter back projection one. And for the external radionuclide source, we can use the dosimetry of transmission scans and iterated reconstruction. So the dosimetry of transmission scan is a solution to the insufficient transmission count density. So the dosimetrics can calculate the effective dose needed to perform a scan with the external radionuclide sources, and the iterative reconstruction is an algorithm to do a rapid reconstruction for attenuation map. So basically, it generates a models and it perform a rough estimate for the image on each transverse planes. Then it calculates a projection based on the forward projection of that estimate and try to compare the estimate with the measured projections and minimize the difference between these two kinds of projection. So once the difference is minimized, they can use the calculated projection as a ground truth instead of the measured projection. And we can see that there are a lot of artifacts in the attenuation corrections. So one question is that is it worth it to apply the attenuation correction to the SPECT image? So the papers mentioned the improvement on diagnostic accuracies on 3 different categories with static ECG-gated image, gender, and obesity. So as you can see in this chart, the sensitivity of static and ECG-gated is improved, and the specificity for the ECG-gated image and the people not in obesity is increased. For both of them is increased, and the sensitivity for the screening patient groups remains the same, but the sensitivity for people in obesity drops. So overall, the attenuation correction is something worth it to try, and it can increase the accuracies. And another thing is that the attenuation corrections can help physicians make a definite decision. So, and it decreases the need for REST image. So for certain situations, the physician only need a stress image to make a decision. And at the end, the papers review several points about the future work and the things need to take care of while doing the attenuation correction. The first one is the attenuation corrected image is only a supplementary to the diagnosis. You will also need a non-corrected image as a reference. And the attenuation correction can cause a lot of artifacts as well as the SPECT imaging itself, so it needs extra caution when doing the attenuation correction. And attenuation correction will lead to a different patient classification and management decisions. So another question is that if the change in patient classification and management decision can help them live longer and healthier. So one thing needs to be done in the future is to do a long-term follow-up about the event rates and the event rate after the change of the decisions and the classification. And the last one is the validation of various approaches to attenuation correction is required to validate the use of attenuation correction in the SPECT image. And that's any questions?
Yeah.
Any questions?
So just a confirmation of like the general idea of it. So you're doing SPECT, but you're also having external radionuclide sources, sort of like a secondary CT, but with radionucleide sources.
Yeah, so as we know, like CT gives a very good anatomy of the human body, but also at the same time it gives the attenuation correction mapping so that we can apply that map into the SPECT that I believe. So that helps the SPECT images to have the actual attenuation. How does that changes depending, because we don't actually know the distribution of the attenuation coefficient in the SPECT, so that we use the CT instead of just using the SPECT only. So that kind of helps to have like a better quality image in SPECT.
So could you describe what the artifact is? If you, like, envision a scenario in which if you don't have the attenuation map, what would happen to your SPECT signal?
Okay, so if you don't have an attenuation map, then you don't know how much signals were attenuated through the body. We got the signals from the patient's body when you injected radionuclide, but I think that gives us a lot of noise. Also, like a very not clear images, I believe.
So let's say you inject someone with radionuclide. Let's say all of it goes to one spot, let's say in the heart.
Okay.
So the nuclide is supposed to go, and this is kind of fictitious, but it sits in the blood chamber. And so in theory, what you're going to do now is detect the emission of those radionuclide decays on the SPECT scanner, right? And you're going to do the inverse of the CT scan and say, okay, all of my energy came from this one spot. So how would not knowing the patient's attenuation potentially obscure that image?
So if you see a dark area in the SPECT image, so you cannot tell if that's for the attenuation or it's for the perfusion defect. So by applying the attenuation correction, you can make a clear decisions about it.
Okay. I mean, the point being that those radionuclides have to get through your body to get to the detector. So the ones that go, for example, through your spine, are just dumb luck. You will detect less of them than the ones that come out kind of like left, right, and don't hit your spine or your sternum. So the idea is you have to account for that attenuation because you know you're going to get less signal along path lengths that have high attenuating objects. You imagine laying with a metal plate on your chest, right? Which you wouldn't do, but your SPECT signal in front of you now would go to 0, right? Because that would be blocked by the object. And so you would have an error in your SPECT scan reconstruction if you didn't account for that. Great. Any other questions?
The SPECT scanner, those are gamma rays, so they're a lot better. Is that correct?
Right, that's a great point. So how translatable is the attenuation you get from the CT scan in terms of its energy distribution compared to the SPECT signal?
So, as I talked about from these slides, they use the radionuclides. I'm not sure what kind of radionuclides are used. I'm not sure how much like energy does X-ray produce, but like these two systems uses the radionuclides that releases around 1 or 3 keV, and the other system is using the radionuclide way much above those energy levels. So I guess using that system is very helpful to determine which signals from it's either going to be from the SPECT or the CT, but if you use the really high energy gamma energy emissions, then you can see from your detector, oh, this energy level is then way above the other 2 radionuclides, which are from the other X-ray or CT. So using that system might be very helpful to distinguish between 2 different radionuclides. But this might, as I said, it might cause the crossover of photons because they have like similar energy. So I think that's.
So I think those are maybe 2 separate points, right? So one is if you're doing this at the same time, and now you have photons that are hitting the detectors with different energies, you don't want to lump them together, right? You don't want to lump the radionuclide that you injected with whatever you're emitting or the CT scan. That's kind of a simultaneous temporal problem. I guess what the point I think you were making was your attenuation depends on the energy.
Yes.
So if you shoot, let's say, X-ray energies that are low dose, and you get a certain attenuation map, and then you now shoot a bunch of really high energy gamma rays, the map that you have is at a particular energy, not necessarily at the one you're shooting at. And so there may be errors associated with the fact that you're not shooting and emitting at the same energy. From a purely attenuation map, you would want to have the same energy photons in those maps. Right? You would make an attenuation map from the same gamma rays that are being emitted, but you would shoot them kind of in a different way. But that, I think, is like you're saying, is like a technological challenge to start to do that, also with those perspectives.
So I'm not sure about how they calibrate it for for a CT system, but for this external radionuclide source, they can use the same tracers.
Right.
Yeah.
Okay. Any other questions? If not, you got homework?
I love these 7 votes.
I haven't printed out.
Okay, great. Thank you guys.
Thank you.
Thank you.